So, yeah, we'll start. But just before we start, since it is such a small group, can I just ask, what you do here at the university?
Yeah, I'm a student here, and then I work at the Barbara Davis Center doing research on technology.
And what's your student focus?
Science.
Yeah. Are you in the first year?
Yeah, well, I'm actually completing my MS this summer and then starting a PhD in the fall.
which
Oh,
is
congratulations.
much improved
I'm a MPH student.
X number of years. It's, they're actually teaching out low now.
You went for the hard stuff, right?
I went for the stuff that nobody wanted to do, yes.
I was working
Yeah, absolutely. Thank goodness there's computers,
just helping the teachers.
Ask you?
Assistant. But we were also doing some cultural.
So close to graduation? Excellent.
Killing
What do you think you'll do in the future?
a 1.5-year-old
Here in Colorado or go somewhere else?
meat
Chicago?
for that night,
Great.
which we ate, which was really something.
Right when she was taking a bite.
So we
I'm a health economist at the School of Public Health.
basket weaving and
Right.
language and so forth. So we were
I
exposed.
know his focus. Don't know hers.
The sign says it starts at 11:30.
Yeah.
Computer. The screen says it's preventive medicine going at
Starts at 11:30.
11:30. Yeah. So make sure you can find.
Wow.
I still, I get notices like the one on the 9th. Apparently you're having a big, School of Public Health is having a
Wow, that's great. That's a huge need. Mental health is, I'm so into prevention and, identifying it early,
They're not the same time. Well, I do if I think about it.
Good, good. Wonderful. Nice to meet you.
So can you look up the,
Yeah. I didn't meet this gentleman.
Sorry. Sorry.
Everybody's just introducing themselves. I didn't meet.
Bill Moraine?
And what do you do here at the university?
I'm an emeritus professor.
Oh.
I ran the residency program before Carolyn took over.
Wow, excellent.
I'm hoping to convince him to come back and take it over again.
Right.
So I was just looking it up online and trying to find out, okay, when did that actually get accredited? When did it start?
When did the program get started?
Right.
It got started in '85, but the first students didn't come till '87,
Okay.
and we were accredited when they came in '87.
So has growth increased since then?
The number of residents?
Right.
No, it's about the same, I think.
Really?
Around 6 to 8, 10.
Mm-hmm.
Yeah, sometimes we at times had 10 or 12.
Yeah, because you'd think nowadays with such a,
Yeah, you would hope.
emphasis on preventive care.
Of course, everybody's getting into the prevention business.
Yeah.
Everybody's into prevention, which is good. Which is really good.
Absolutely.
Which is good.
All right, so why don't we just get started? It's going to be a small, intimate group today. So first thing, if I could just make sure to ask everybody to sign in. Sign-in sheets are at the corner end of the tables there. Thanks for joining us today at Grand Rounds. This is going to be the last Grand Rounds, Preventive Medicine Grand Rounds session for this academic year. And today, our guest lecturers are Dr. Andrew Martinez and Andres Guerrero, and they're going to be talking to us about correctional health. And Dr. Martinez is a graduate of the University of Colorado Health Sciences Center, and he completed an OBGYN residency at the University of Rochester. His current position is the Chief Medical Officer at the Colorado Department of Corrections, and he completed a certificate program here with a focus in the health systems management and policy. He's joined by Andres Guerrero, who is the viral hepatitis prevention coordinator at CDPHE, and he is also currently a candidate in the certificate program with a focus on epidemiology.
Thank you. Would you like to say anything? What your focus of your presentation will be, or?
So basically, the focus of the presentation today is going to be looking at, for my portion of it, I'm going to be explaining some of the risk factors, because I think a lot of times folks have a lot of misconceptions about what happens in prison and what those risk factors might be, or it might be exactly what you think it is. And then the other thing I'm going to talk about a little bit is just possibly some prevention activities that could be undertaken.
So thank you for inviting me to speak about correctional health care. It is, anytime you have a healthcare delivery system in a large organization, it's very complicated. Then you put corrections on top of that, and it even gets more complicated. But I think it has many interconnections with preventive medicine and public health. So you're here for a reason. You must be curious or have questions about correctional health care, or understand that it is certainly an underserved population. I'm here for a reason, and that is my goal is to promote interest in correctional health care, create elective internships, practicums, and research. And hopefully those educational opportunities will enable students to take those interactions in correctional health care back to what you do best, and that is to develop strategies for early interventions, substance abuse, mental health problems, risky health choices that led to incarceration. I'm working with one student, Leah, and she wants to come into Department of Corrections to sort of clean up our HIV database, work with our nurse case managers to enroll paroling offenders in Medicaid and help them gain access to health care in the community. And I'm hoping to show that this approach will improve health outcomes, decrease morbidity, and serve a public health need. I know you already know that preventive medicine can have a huge impact on healthcare costs, but it can also impact the enormous costs of incarceration. The incarceration rate in the U.S. is the highest in the world, 743 per 100,000 population. That's 1% of the adult U.S. population. The U.S. represents 5% of the world's population and houses 25% of the world's prisoners. I thought that statistic was just unbelievable. And you just have to ask yourself, why? And I don't know if anybody's really come up with an answer. This is sort of an outline of what I want to talk about, sort of structure of DOC, how prisoners are sort of invited into prison, the healthcare challenges, some morbidity statistics, costs, of course, and then focus on hepatitis C and how that's has a big impact on the offender population. So there are offenders in county jails all across Colorado who have been charged, gone to court, and been sentenced, and hopefully detoxed, and await placement in the Department of Corrections. This is where they arrive at the Denver Reception and Diagnostic Center, which is right down the street over here on Smith Road. It's not very far from here. And if any of you are interested in tours, I really like giving tours. And I've been told that it's very eye-opening. It's not what you expect. People expect prisons to be very scary, and they're really not. They're very controlled. There's controlled movement. There's times when you do things. If you act up, you know, they can take care of it. So there's also a women's permanent facility there that has lots of opportunities for practicums and recruitment. Normally, there are usually 200 offenders in a backlog, and DRDC can process 45 of them per day. And in the next few slides, this will show what that entails over the course of 4 days. It's called programming. And you have to realize that most people that come into prison have had very few interactions with the healthcare delivery system, if any at all. So disease processes have progressed further than you would ordinarily see in a normal community healthcare setting. So any questions about any of these? So they're also given M codes, P codes, SA codes, SO codes, and custody codes. So what are those? It's a scale from, boy, you can't read that very well. It's a scale of 1 to 5 that defines medical needs, medications, disabilities, mental health needs, dental needs, substance abuse, and sex offender treatment needs. And custody is either minimum, mid, medium, or close custody. So a programmer is essentially a case manager that works with offender services to determine where an offender can be placed in the system, because all facilities are not the same. Some facilities can't accommodate people with disabilities. Then there are facilities that are medium and can't have close together. And then there's also certain facilities that have treatment programs for sex offenders in particular, and other facilities don't. So all that determines where the offender is going to be placed. So the goal is to accomplish all this in 4 days and then transport offenders to their permanent facility. Some offenders can never leave DRDC, although it's considered a transition unit because they have cancer treatment, they're on dialysis, and that can only be done at DRDC. And it's one of 2 infirmaries in the Department of Corrections. So these are the different facilities in Colorado. You can see there's a high concentration in Canyon City, and they're all different levels of custody, from minimum to, that's where we used to call it the maximum security Colorado State Penitentiary. But the minimum facilities there are really interesting. They have, they're kind of like no fences. These guys can go out and work. Some of them fight wildfires. Some of them grow tilapia. Some of them work in the nursery and raise, I think, some kind of cattle that has that they make cheese into. So the whole purpose is rehabilitation. I mean, we really want these guys to come in, get treatment, and have a job. And, you know, their jobs actually, they can make money and bank it and spend it on all this junk food in canteen, which is not good for diabetes. But this is home. This is a facility in Canyon City, and it's one of the higher level custody facilities. But in each of the facilities, there is a clinic, and it's very much like a clinic you would see in any community health center. There are nurses, mid-level providers, a physician, and of course we take care of the offender's needs in chronic health care, chronic care clinics, emergencies, lacerations, splinting, vaccinations. So there's a very rigid kind of standard. If an offender comes in, it can be seen by a nurse. There's a nursing protocol, and she goes through, checks things off, and decides, can this be treated, can it wait, or does he need to see a provider immediately? And we also have clinical standards. There's 80 of them. And the reason we have those, they're kind of like guidelines to how we provide health care. Because we're working in such a big organization, we kind of have to organize and say, this is the way things are going to be done. And I'm constantly telling providers and people, look at the standard. It tells you right there. How do you treat TB? How do you treat hepatitis C, hepatitis A and B? So there's 80 of them. And it really gives us more organization to treat the things we need to treat in corrections. We also have a third-party payer. It's called Correctional Health Partners. And they kind of decide, it's utilization management, they decide, can we send this offender out for a specialty consultation? Have you done this and this and this? Because it's very expensive and it's risky. Whenever an offender leaves a facility, that puts citizens at risk. So we kind of want to make sure this is absolutely necessary. We also want to make sure, okay, this guy came in with a torn meniscus. We're not going to fix it because he came in with it, unless it really affects his activities of daily living. And a lot of offenders come in with hernias. We don't fix those until they affect activities of daily living. But, of course, the offenders are always grieving. I want this fixed. I want this done. And there's a process where they go through grievances, and we respond. Then they have a level 2 grievance. We respond. Once it gets to a level 3, then it's pretty serious, because then if it hasn't been responded to in some manner, they can actually sue the Department of Corrections. And it's not really suing us for medical malpractice, it's suing us for deliberate indifference, which means that's a civil rights issue. It's not a medical malpractice issue. And we get lots and lots of those suits. So here's some of the morbidities in DOC. I'm not really happy with the numbers for diabetes and hypertension. There's so many places in Department of Corrections you can get statistics. You can get them from our information technology people, from planning and analysis people, from our correctional health partners, and I really think they're higher than this. And I didn't have time, sorry, to really look into it more effectively. But the prevalence of diabetes in the community, according to MMWR, is 8.3%. The prevalence of hypertension is 30%. So that's why I think these numbers are low. And also, the way we determine the statistics is CPT codes that actually have to go into the electronic encounter, and sometimes those aren't done very well by the providers. But if you look at the prevalence of Hep C, that's huge, because in the community it's less than 2%. That number I have more faith in, because what happens when they come in through intake, we do a panel of lab tests, HIV, Hep C, Hep B, CBC, metabolic panel. And so those are recorded and followed by the Infectious Disease Committee. So that statistic I'm much more comfortable with. And these are the need levels of the offenders. So you see, DNA means substance abuse for men and women. So there's a huge substance abuse issue with offenders coming into prison, and also mental health. And it's interesting to see that the mental health needs of women are almost double that of men, and also the medical needs are almost double. And medical needs mean chronic medical conditions, diabetes, hypertension, COPD, and also the percentages of violent offenders and sex offenders. Yes?
Dr. Martinez, what's the general average age of your population?
Of men or women? For some reason, the women's median age is much lower. It's more like 24 to 30. Men, we have some very old offenders in prison. And I would say the men are a little older. I would say that would be 35 to 40.
Well, that would affect a great deal the incidence of your, or the prevalence of your diabetes and hypertension.
Right. Right. But there are some very young male offenders as well. So let's see. So these are the costs of clinical services, which is a division within the Department of Corrections in this fiscal year from 2013 to 2014. So providers cost $29 million a year, and outside medical services are $20 million. That's when we would send an offender to an outside consultation. They had to go to the emergency room, they had to go to the hospital. Then there's a little bucket of money for what are called catastrophic medical expenses, and that's $12 million. And that's because sometimes we have people in the hospital for months in intensive care units. And some of those offenders are what we call self-injurious. So they'll swallow razor blades, they'll swallow tiles, and have multiple exploratory laparotomies for bowel resections. So they use up that money. So in total, if you look at mental health costs, drug and alcohol treatment, sex offender treatment, it's more than $100 million per year. This is the total DOC budget. So in 1 year, to take care of the health care, maintain facilities, pay for correctional officers, it's almost $800 million. And you can see the amount of federal funds is very small. So most of this money comes from taxpayers of Colorado. All right. So what I wanted to just focus on next is treatment of Hep C in correctional facilities. It's like we can't treat everybody. The costs are enormous. So we go through a protocol where we have the provider say, do all these tests. Is it necessary? How far progressed is it? Is it decompensated liver disease? Can we wait? And some offenders, they don't want to be treated. Others are saying, oh no, this is a life-threatening disease. You need to treat me. So there is a whole entire process that we go through to treat them. And there are many questions, philosophical issues about treating them, and that's what I think we can discuss after Andres' presentation. Thank you.
All right. So, as Dr. Martinez said, hepatitis C is a huge issue in prison. And it was really nice to see the numbers because nationally you're looking at hepatitis C in prison systems anywhere from 13 up to 41% in some cases. So it really is very much higher than what we see in the general population. These prezzies are funny because when I'm looking at them from out there, I tend to get dizzy. So let's see if it happens when I'm up here looking at it. So some of the risk factors associated with viral hepatitis. There is a lot of tattooing and a lot of body art with reused non-sterile equipment, so that's definitely a risk for hepatitis B and C. There is a lot of unprotected sex, both consensual and non-consensual, and that puts somebody at risk for hepatitis A, B, and C. And believe it or not, there is also injection drug use that happens inside of prisons, so people are also at risk for hepatitis B and C through that.
How does that happen?
It's interesting, right? I'm sure you've heard stories about how people are able to do that. And there's some real specific challenges when you're looking at a correctional environment. First of all, it's a security environment. That is their paramount, purpose is to have security. And so a lot of the things that we would normally use for prevention out in the public, we cannot use in this environment. Things like condoms, things like clean syringes, things like that are not something that we can do. Also, we find that there's a lot of myths held by inmates. So just a little bit about my background. Before I worked for the State Health Department, I actually worked for a number of years with a private nonprofit organization, and I was working with guys that were coming out of the prison system, and I was doing drug education. I was doing HIV and hepatitis prevention. And so when I got to have this one-on-one contact with these folks that had just been released, I learned about a lot of these different myths that people held. I think the most common when I heard about hepatitis was people thought that when you first got hepatitis, you had hepatitis A, and when it got a little bit worse, it would turn into hepatitis B, and then when it got really bad, it would turn into hepatitis C. That was something that I heard from multiple people. Another big challenge is that funding is limited, as you saw from the earlier slide. It's a huge amount of money, and it's mostly state money, and so when the state budget gets squeezed, Dr. Martinez feels it at the corrections, and I definitely feel it at the State Health Department. We don't get much to work on hepatitis prevention from the state. The little bit that we do get, it hasn't happened in the last couple of years, but when times get really tight, they go after that money. And we'll have to go and say, no, really, it's not much, but we really need it, because that's one of the first places they're looking to make cuts. A lot of co-occurring disorders, mental health issues with people with hepatitis. A lot of times they have substance abuse issues in their history. And a lot of times when they come to prison, as Dr. Martinez had said, this is the first time they've really had any kind of health care at all. Do you have a question?
No, sorry.
Oh, okay. So also as prevention professionals, there is a definite lack of accessibility to the inmate population for folks that are working on the outside to get in. I saw that firsthand. The reason that I ended up working with folks as they were coming out of prison is because I was unable really to effectively get myself into the actual prison to work with them before they were released. And as you can imagine, when people first get released, that first week to 2 weeks, that is when all sorts of risky activities are going on. So if they were infected while they were in prison with something, they have a tendency in those first couple of weeks, they are partying it up, they are, having sex, they are doing drugs, doing all the things that they might have been doing beforehand, and they're really doing it very heavily for those first couple of weeks. That's why I was really concentrating on them right as they were coming out. Cost of treatment, it's extremely expensive to treat hepatitis C. Confidentiality is another issue. This is just something that I heard anecdotally from the people that I was working with. They always said that you knew who had what based on where they were going in the clinic and who they were talking to and what type of medications. That, if they know they have to take medications at certain times of the day, people after a while will figure out, well, those people that are all going to get their meds at that same time must have this. Another big challenge is that the risky activities that they're engaging in are punishable offenses. So it's extremely difficult to get somebody to open up about what the risk activities might be if it's something that they can get in a lot of trouble for. So that would be the illegal tattooing, that would be any sort of sexual activity, all that sort of stuff that will put somebody at risk. They don't want to talk about it because they do have the potential to get in some trouble for that. And I don't know how much of it is an issue now, but when I was talking to folks previously, medication adherence would be something that would be difficult. Sometimes they said people, especially with mental health issues, would not want to take the medications as they were supposed to. And so that could be a challenge. So let me show you this quick. This is just a 3-minute video.
Important to the inmate.
Where their attitudes on their arms, I guess you'd say, in a lot of cases. You have...
Let's see. Whoops. Sorry. I don't know how to start this video over.
Can you drag on the progress bar?
Yeah, that's what I just tried to do. Let's see. Oh, there it goes. Yep. All right, there we go. So this is just somebody that's actually doing tattoos in prison, and he talks a little bit about how the risk that he sees.
Explain something to me. Why are tattoos so important to so many inmates?
It's really hard to say. Sometimes I think maybe it's a status symbol, maybe, or a fashion statement, whatever. People wear their attitudes on their arms, I guess you'd say, in a lot of cases. You have people that are proud of their neighborhoods, families, heritage, all kinds of different things. Some people just want the art. Other people don't care what they get. It's just something to say they were in prison, the tough guy image and all that.
Can you give me a little bit of an understanding as to how you do it, what you use, what your tools are?
Well, we make tattoo guns, out of like Sony Walkman radios, the little tape players. We use the motor, use ink pens, utilize paper clips, guitar string, and tape and rubber bands. A lot of us make our ink because real ink's hard to find.
You hear a lot of concern about health issues when you talk about prison tattoos.
The health issues, unfortunately, not a lot of people practice any kind of sterilization, which causes, the spread of hepatitis and so forth. I worry myself about contracting things or passing it on to, as it stands now, my liver's in pretty bad shape. It's failing on me. And I don't want to pass anything I may have on to somebody else, and vice versa. So I use, I use equipment on one person only, and then if I work on somebody else, I use a whole brand new setup, I use the same motor and so forth, but it's all different needles and barrels. I never reuse ink or any of that.
And I was talking to you before about payment. And you were saying, you know, this is kind of a poor man's operation here.
It is. You know, we're all in the low income bracket in here, and you know, you can't really tax people in here like you do out there. You know, when you're tattooing. You know, because most of us come from poor backgrounds, poor families. You know, and a lot of us have children, man, that are being supported by wives. You know, because we're not there. So, you know, payment. I work with all monies. You know, on the basis that all money's good money. I accept stamps, cosmetics, whatever. You know, that's available to me. You know, or whatever anybody can work with. You know, and I'm easy with people. I'm not out to rob anybody. You know. If I do a back piece, like a full back piece in here, I'm charging anywhere from $100 to $200. You know, and I work out payments with people. You know, where it's easy to, you know, easy on everybody.
If they see you doing it, if they know you're doing it, you're in trouble, right?
Well, in theory, yes, and sometimes in practice, it all depends on your staff. You have to kind of pick your shots, you know, when you tattoo and when you don't in here. Sometimes they're, you know, they turn a blind eye to you.
So that was not in Colorado. That was actually a prison in California. But I think it does show that there is some serious risk going on. I had one gentleman that I worked with. I've worked with him when I first was working with guys that were coming out. He got out, he immediately reoffended and went back. And what happened was, when he went back, he found that the tattoo gun that he had made several years before had actually been in circulation, and then he was able to reacquire it when he went back. And this was after about 3 years. And so like that gentleman said, he doesn't use the same needles and the same, you know, barrels. He just uses the same motor. That's not the case in most instances. It's a matter of necessity that they have to use the same thing over and over because it's extremely difficult to get those pieces and actually make this stuff. The amount of ingenuity by these guys is absolutely astounding. What you see, what they're able to make out of all sorts of stuff. Even the inks themselves, they'll use. They told me that there's certain types of paper that'll burn down to an ash that makes a good ink. You know, so they're actually burning little pieces of specific types of paper that they find in order to get the ash to make the ink to do the tattoo. So everything is, you know, risky, really. So some possible solutions from a prevention standpoint. I think one of the most effective is peer education. So making sure that you're able to find somebody within the system, preferably an inmate, who's willing to learn about hepatitis, HIV, and other communicable and infectious diseases, and then be able to take that information and give it to the other inmates. Because generally when you're talking to this population, you can come in as a professional, and they generally will not pay as much attention, or you will not have the credibility that somebody from their own peer network is going to have. It's almost the opposite. If you come in with a lot of education, they almost look down on that in certain ways. Whereas if it's just one of their own giving them this information, I think they're much more open to listening. This is something that has happened in other countries. I've never known it to happen here in the United States, but there is places where they will actually come in, have professional body artists come in on a regular basis as a reward for good behavior, and actually do tattoos with obvious limitations on, you know, gang tattoos and things like that they won't do, but just other types of tattoo work can be done. Yeah. And so it's first of all, you're reducing the risk, but second of all, you're also, they want that professional tattoo. And so they'll you know, try to stay out of trouble for that amount of time that they need to. A couple of years ago, we did have a little bit of extra funding. So we actually bought a whole lot of books. It was Living with Hepatitis C and Living with Hepatitis B. And then we sent those down to the Department of Corrections main office in Colorado Springs, and those were distributed out to the libraries. So what we find is people want the information. It's just a matter of getting it to them. And then also some different things to work on reducing stigma, because there's still a lot of stigma around HIV, around hepatitis within the prison system. So I'm going to show you just a very brief video. This one is actually made in San Quentin, and these gentlemen that you're going to see are actual inmates. And this is a peer education project that San Quentin Prison started, and this is one of, I'd say, about 5 videos that they have. They are on YouTube. But this one I thought was pretty interesting. It's called centerfold.
Hey, what's up, Yada? What's up, homie? What's going on?
Nothing, boy. Checking out Weezy's task, boy. Boy, Raw. My partner, he gonna hook me up this weekend with a couple of sleeves and stuff, man. It's gonna be some fly business, boy.
Yeah,
man.
that's pretty tight right there, man. But
Yeah.
check it out. What kind of precautions are you taking, though,
Bro,
bro?
I got a couple of my partners from the town watching police for me. It's gonna be cool.
I ain't talking about them kind of precautions. I'm talking about health precautions, man.
Oh, I ain't tripping on none of that. It's all good. My boy, he's straight. Trust me, he's straight, man. He's straight.
Look, I know you trust your homeboy and everything, but check this out. There's some things that he might not know. First of all, hepatitis C is passed through blood-to-blood contact. And this stuff is so small, man, you can't even see it with your eye. So it's passed through sharing razors, sharing toothbrushes, sharing drug shooting equipment, sharing them Visine bottles that they be sniffing hop out of and all that. Them cats they be pocketing them pills and all that. It's passed through. It can be passed through all that, and especially tattoo equipment. When I say equipment, I'm talking about the needle, the barrel, the ink, everything.
Oh, man, y'all, man, I ain't tripping on that. My boy, he got that on lock. He got Cell Block 64, all that disinfectant stuff. Man, he be on some mad scientist stuff in his bunk area, man, boiling his needles. He good, man. Trust me, he's straight. He tighter than them dudes Weezy be getting hit from.
You know, that stuff sounds good, but all those jailhouse myths about cleaning and everything, none of that stuff is guaranteed to kill the hepatitis C virus. Boiling it, burning the needle, all that stuff. None of that stuff is proven to kill hep C. Matter of fact, I got this fact sheet right here that talks about it. These are facts from the Center of Disease Control that talk about hepatitis C. And these people are like the authority on all the disease control stuff in the United States, right? And this fact sheet right here talks about how hep C is spread, how you can protect yourself, the body fluids that it's found in, the whole 9 yards is right here on this fact sheet. We fixing to get this class, man, at the end of the week. And you can come and you can bring your homeboy with you.
You know
Come
what?
check it out.
You know, because you my partner, man. You know what? I'm going to hold off on that. And I'm going to check in with him and see if we both can come to see if he up on his business with that, man.
Hey, for real, man, you should think about doing that because this is serious business.
All right,
Hepatitis C is a serious, serious issue in these kind of settings, bro. So you need to take care of
Man,
your
good looking out, Yada.
all the time, bro.
All right, man.
I hope to see you there.
All right, bro.
So obviously that's a little bit it's a little cheesy, right? You know, but the main premise there is to have people with their own peer network and education network. They could be from, you know, a professional or a, you know, a healthcare provider in a lot of cases. There we go. All right, so any questions about that?
So I think a really big issue is the cost of treatment. What it currently costs now to treat an offender in prison is $40,000 for a course that lasts anywhere from 24 weeks to 48 weeks. One of the drugs is interferon, which is injectable, they get once a week. The other drug is oral. Some of the offenders have such bad mental health problems that they have side effects on the interferon and they have to stop. So the new drugs that are coming out are all oral, they don't include interferon, but the cost is $90,000 per 12-week treatment. So it's very hard to convince Colorado legislatures to treat people in prison, even though it's a life-threatening illness, with the new drugs. So you kind of have to present it to them like, well, this guy's going to be with us forever, so we might as well treat his hepatitis hepatitis, so we don't have to deal with his end-stage liver disease, so we don't have to deal with his GI bleeding, hepatic encephalopathy. He might listen to that. Other offenders who are going to be released back into the community, then you have to think, what is going to happen? We treat them for $90,000. They go back to the community, which is a good thing because that's decreased community viral load. But then they get reinfected. And a lot of offenders come back to see us. So of course we're not going to treat them again, but there we just wasted $90,000 in the taxpayers' money. So it's really complicated.
Yeah, but the cure rate with the new medication
Double.
is 90%.
Yeah.
Versus 50%
Right.
with interferon. So I think you can use that as a good argument, but I mean, obviously it's the long-staying prisoners that you want to use that for. Yeah.
But you're right, yeah, the viral response right now is 50% sustained viral response, 50% versus 92. I mean, that's amazing. And I think the new drugs that are coming out in the future are going to probably be even better.
Even better.
AbbVie's applied for their FDA approval, so they should be coming out relatively soon.
Who has?
AbbVie. AbbVie has a new one, which is not going to have the interferon anymore. It's going to be the interferon-free. Yes.
Do you get pushback from legislators, like, well, they deserve it, you know, they've done bad things, so why should we treat them? That kind of attitude, which I remember was the case with HIV when it was initially being diagnosed in gay men.
You do see that attitude. And you also see it in what's called victim services. So you hear stories. I mean, these guys did some bad things to people. And it's sort of like there is a little bit of resistance to like, why should they get such good health care in prison when they really ruined my family? I mean, you got to balance it, you know, because I think the majority of offenders really want to go in, they're detox, and they're not using drugs anymore. All of a sudden they realize, God, what did I do with my life? You know, and some really do try, you know, get a job, go to classes, and so the majority, I would say, do. Some people in prison are just evil, and you know, they just need to be there forever. But yeah, you have to balance.
How likely is it that somebody who's infected, treated, will get reinfected while they're still in prison versus
That's
on
a
the
good
outside?
statistic. I don't know. I'll work on it, and I'll let you know next time. Another good statistic would be, okay, how many of the people we treated in prison for Hep C were released and then got reinfected? You know, that's going to be a hard statistic to get, but a lot of times they'll come back. So returning offenders that come back into prison and look at those numbers, it's like, oh yeah, we treated him before, and now he's Hep C positive. Because they'll get tested again when they come back in. That might be a little easier to find.
One of the statistics you didn't mention was the prevalence of HIV positive.
It's pretty low.
Is it?
It's like probably 1%, 1.5%. And we do treat all of them with the most up-to-date
Sorry.
drugs.
Yes.
Do you know if there's any data, or has anyone looked at the prisoners who get released who aren't treated, who go back into the community with any of these diseases, how much they then spread it to wives or spouses or friends or children, or do you know, like, is that a way to, like, justify
That would justify.
cost of treatment if
Sure.
they're not spreading it to the innocent people in the community?
I think that kind of research, that kind of data is probably going to be easier to obtain now that offenders have better access to health care when they're released in the community. So they're going to have Medicaid now, you know, vast majority of them. So then we can like sort of track them through health, community centers, and that sort of thing, and get that kind of data. But if they don't have insurance and they just go out and they don't go to health care, who knows?
I think that's also a big misconception by the public is that they don't realize that the vast majority of these people will be back out again. It's a very high percentage that go back out. Very few are in there forever for the rest of their lives. A lot of them end up coming back again, but it definitely, people tend to have the mentality of, well, it's prison, they're there because they did something, they kind of deserve it. But if these things aren't dealt with in the correct manner, they come back out to their communities with those issues, like you said. And that issue could be a infectious disease, it could be a substance abuse issue, it could be a mental health issue, it could be any of those.
The only ones that are really trapped for life outside of prisons are sex offenders. Well, thanks for listening.
Question?
Oh, another one?
Yeah, and on the graph that you showed with the dependence or the substance abuse, I think it was like 80 to 90% of folks. What is classified as a substance when folks are coming into prison? Like, is tobacco called a substance abuse issue?
It's mainly illicit drugs and alcohol.
And do you know more or less how it breaks down?
Into IV drug users?
Sure, like cocaine,
Huge
heroin, or
amounts of
something.
IV drug users. But it's really funny because, substance abuse goes hand in hand. You don't just usually do one. You're doing a bunch. So it really is hard to break down. Oh, that's it. Yeah.
Yep, that's all. Yes?
You might have already mentioned this, but what's the incidence of Hep C infection in this population relative to the same demographic population?
In the general public?
Yeah.
It's definitely quite a bit higher in the prison population.
It's 60, well, it
Yeah,
depends
so we
on
had-
which prison. I mean, some, DOC, it's 14 to 16%, and that varies by year. Certain years it goes
That's
up.
prevalence or that's incidence?
That's prevalence. Yeah. And then according to, like I said, the morbidity mortality report, the prevalence in the general population is less than 2%. That's it.
So one of the issues that we have at the state health department is a serious lack of funding for hepatitis, specifically surveillance, disease surveillance. We lost our federal funding for surveillance, gosh, I want to say it was about 2-3 years ago. And so from that point on, we are literally relying on students to do surveillance. So we've definitely been missing a lot of acute cases. We've definitely been missing a lot of cases in general. It's just the nature of the beast. We just don't have that funding available to us anymore to do that. So it's really hard to get that data.
So is the incidence going down? I've seen graphs that
Yeah.
show it is going down.
It is going down. So what you're seeing lately is you're seeing, the baby boomers, that kind of bubble at the end. And then what you're also seeing over here is a little bit of a bump with young injection drug users, where you also see that little increase, and then you see the big bolus of folks who were born between 1945 and 65. So what we're trying to do is really target those young injection drug users before they get infected.
So, you could get an incidence since you're checking everybody at baseline. Do you test at any other time? Like, do you have annual screening for Hep C or anything like that?
Or Hep C?
Yeah, I'm just curious if you had a way to see whether people were getting it there. I imagine a lot of people have it when they come in.
Normally, if they're symptomatic or if they request it,
Oh, I see.
that would be the only reason we would do it.
There's no sort of routine screening
You don't
process.
screen for hepatitis C like you do for HIV.
No, we do
At
initially when they
baseline,
first come
yeah,
in,
but
at
I'm saying,
baseline.
do they do
Right.
it subsequently?
Yeah.
But at periodic health screenings, would we do it? No.
Okay.
What percentage of inmates would you say have tattoos?
I could guess.
Yeah, right.
Just working with the folks that I was working with when they came out, I would say probably 60% have gotten tattoos while they were inside. As far as ones that had tattoos before that, you're probably looking at 80%.
Right.
Yeah.
And
And it's some extreme tattooing. Facial tattooing, just tattoos. You when you see the people on the street, they've been inside.
But we can go on to an intranet that's called Offender Portal, and we can see each time this guy came into prison, there's a mugshot. Well, there is this one guy that came in, first thing, nothing. Next year. By the time, like 7 years later, his entire body was covered. It was scary.
Yeah. And it's unfortunate because a lot of these folks, it makes it very difficult for them when they get out to be able to find work, to be able to reintegrate into society. You know, it was an eye-opener for me working with people that were in the parole system, that they were able to be sent back to prison for what I viewed as very minor things. I remember one person got sent back because he could not afford to take the UA that he was required to take for a drug screen. It was, I think at that time, $14. He didn't have $14. He came to the appointment and explained the situation. Look, I don't have any money to do this. I'm having to pay restitution. I'm having to pay child support. This was the last thing. I just don't have money, but I'm clean and I want to drop, and they wouldn't let him drop. Well, when you don't do the UA, that comes back as a hot UA. Basically, that's what it's counted as. So really what you're looking at, in a lot of these cases, there are economic factors which are playing into who's going to prison and why they're going to prison. And in my experience, the slide is dead on. Most of these people have serious substance abuse issues. And when you had asked earlier, why do we have such a high rate? Well, when you see what happened, you know, when Richard Nixon declared the war on drugs, you see that inmate population just go up and up and up, and it's never come back down since. So I think that does have something to do with it.
What about the extent to which the mental health workers work with the medical staff?
Inside of the prison system?
Yeah, with patients and so forth. 'Cause there's
Well,
obviously
typically,
a lot.
the mental health or behavioral health people will work with the offenders one-on-one. You know, go to treatment programs, go to groups. That's
But
what
they don't have anything to do with, they don't share that information with.
Oh yeah, we all share that information. And sometimes someone comes into the clinic and they're just like crazy out of their mind. They'll get a mental health evaluation as well as a medical evaluation. Yeah, so we do work hand in hand.
Dr. Martinez?
Yes.
Thank you very much.
Thank
for
you.
joining us. And thanks everybody for coming.
Thank you.
Yeah, thank you.